So Brenda Larkin, what can I say? Brenda Larkin, I've known forever. But she's been a super advocate for anything that's innovative, anything that is pro-patient outcome, positive outcome. As e-chapter president, I was very fortunate to have her as a champion of all the things that we were trying to do in that chapter, is try to pull it together as a community. And she always gave very strong moral support. She's a fighter. She does not back down when she has an opinion about something, so I really appreciate that about her. And she's also our nurse practitioner, so we really, clinical nurse specialist, sorry, clinical nurse specialist, you're an advanced practice nurse, but it's all the same. So we'll give her a hand. And then we have Rebecca Wortman, who is a personal confidant of mine. She is, most all these folks up here are advanced practice or have DMPs or PhDs or some alphabet soup that goes way longer than anything you've ever seen. So get to know them a little bit. They are very experienced. Rebecca and I met through e-chapter also, and she's been a stalwart role model on efforts to have AORN give nurses give back to the members, and she was very influential on that. She's been an educator for our future nurses. She does not fail to respond to our needs. Whenever you need something, you just take it to Rebecca. She'll help take it to the board and get things done or discussed anyway. She takes care of business, and I truly appreciate her willingness to travel all over the place where she's been. I don't think she's seen her family in probably a couple of months. So give Rebecca a hand, please. Darlene Murdoch. What can I say about Darlene? Let me just tell you something. Last time we had the council meeting here, I asked her a question, and within days, I thought, most of the time you ask people, yeah, they're going to respond. She was on the email. She called me back immediately. She responded to my request. She took it to the next level and got back with me with the outcome. I could not believe it. She is a servant leader, and so sometimes you can ask her a question and she'll say, I don't know the answer, but I'm going to find out something for you. And she follows up, which is the key sign of a leader. She loves AORN. She loves the entire team of surgical services. She is a staff nurse. So when you talk to her, she can relate to people that are working at the bedside. So it's like you talk to her 1 year, and the next year she's your best friend. So she never meets a stranger. Give Darlene. Erica Besora, she is run for nominating committee. And Erica is a personal colleague of mine. She works at Northside Hospital with me. I've known her since she was a baby OR nurse. And she has grown up the ranks, and now she is a, what do they call it? Clinical specialist in quality and education. And she keeps us on our toes when there's any kind of injury or error or something done. She takes care of it. So she's a force, and she's a true Renaissance woman. She's a mother, teacher, nurse, author, publisher, and she's totally exemplifies what it means to be engaged. She's another social media guru. She knows how to promote. She knows how to communicate, and she's serving as our treasurer on the Georgia Council this year, which I had to twist her on to be with. Deborah Calendar. So you're from Florida. She's from Central Florida. She's president of Florida. She's a nurse executive, and she's an adjunct professor. She understands the business of surgical services, and we need that at the table. So please give a hand to Deborah. She's running for chair. I apologize. Y'all's names were not on mine. Please, I'm going to give you the microphone.
Hi, everyone. My name is Leslie Petrozelli. I'm a DNP. I am a consultant for Periop, and I do many different projects. I also do interim leadership. I think one of the things that I enjoy most about interim leadership is diving in and finding out who in the staff wants to do more, wants to be more, but was never mentored or what their goals are. And so it's a lot of fun for me to really bring those people up because there's a lot of hidden gems out there. I'm running for the board and I'd really love your support. I have board experience on surgery center boards. I take this job very seriously. AORN, it's a enterprise. There's a lot of financial stake and it needs to be managed properly as it is now. So it's a lot of work. There's a lot of decisions to be made. So I look at this as a great opportunity. Thank you.
Hi, everybody. My name is Joanne Boyko. I'm from Houston, along with I'm a nurse scientist with a periop background. Fresh out of my program, I did CV, thoracic and vascular, organ transplant, procurement. So periop is very near and dear to my heart. One of the things that I'm very passionate about is really bringing nurses along with me, especially periop nurses with me, to help advance the profession in research and unity and QI. I think sometimes the periop area often gets left off the table when it comes to those really sort of big initiatives, and it has really been my mission to bring the periop area into that sort of strategic plan. How do we move the profession forward based on evidence and research? So that's kind of what I'm really passionate about. And I would not be here if it were not for people who had mentored me and taken me along with them. So I hope that through the nominating committee, if we're elected to that position, that I will be able to help bring people along so that we can when they see more, they see more. Thank you very much for your support.
As people come that are on the ballot for next year that have not arrived at this point in time, I just do want you to be aware to introduce yourself. Do not be afraid to introduce yourself. Please step up to the plate and just ask them any questions and kind of pick their brain about what it is that they want everyone to achieve. So thank you so much for everything. Appreciate it. I want to also thank Striker for sponsoring this welcome reception. So thank you very much. I also want to tell you that we have 2 education sessions going on to the right. And I'd like y'all to make sure that you attend those education sessions. They are worth contact hours. So if you get a chance while you're meandering about with the vendors, please take your time and listen. Our first education session is with Ivy Montgomery. And she's going to be over here talking about the
Alrighty, can you guys hear me? I'd like to start with a couple of reminders. This evening's welcome reception is compliments of Stryker. We truly appreciate your support. Breakfast will be available tomorrow at 7 a.m. in the registration foyer. Education will begin at 8 a.m. in the Laurel Amphitheater. It's right around the corner from the registration desk. Make sure to visit the vendors this evening, as this conference would be possible without their support. A few housekeeping notes. The sign-in sheets will be passed around the room. Please enter your names so we have an accurate head count. If you're seeking continuing education credit, please be sure to scan the QR code located on the sign-in sheet and complete the survey. Certificates of attendance will be emailed next week. And finally, it's my pleasure to introduce your speaker today. Hello. Hello, hello. You guys hear me? Yes. All right. Should I start? Sure. If you guys would like to head over to the chairs over here, we're about to begin an education session. Thank you. All right. Looks like people are still trickling in. Go ahead and take a seat if you could. I remember you, Lisa. Good to see you too. Okay. All right. So if you guys can hear me in the back, great. If not, at least I got a simple audience here. So let me ask you guys this. How many of you worked today? Worked a full shift? There you go. And how many of you hiked up to the top of Stone Mountain? You worked full shift and you hiked up. Okay, congratulations. Not today, in the past. Okay. So for me to have to keep you guys entertained for the next half an hour, I know it's a pretty tall order. But I will try my best, and at the end, if you guys pay attention, I will lead into a magic trick. So yes, I came prepared. So let me get this little clicker going. The topic today is work 2.0 contact hours, but I will only deliver it in half an hour because quite honestly, I won't be able to talk 2 hours. The topic is on the retained surgical shocks patient safety. Just some housekeeping, this is a continuing education provided by Ziller, and the funding is provided by Melzi Corporation. And now it's a turn, you to now a phone and take a picture, not of me, but of the QR code. And if you could just take a photo and so that she gets the link later on. There you go. Let me step aside. I know Lisa's like, move. All right. Oh, we got workers coming in. Come on over. We got seats up here, front row seats. Magic trick at the end. Okay. So, let me introduce myself. My name is Ivy Montgomery. I am an economist. I'm not an experienced surgical nurse like you guys. But like I said, as an economist, what I like to do is look at data, explore the data, and figure out what are the policy implications to make a difference. So that's what I do. And today, what I'll try to do over the course of the next half an hour, it's not to just make you guys memorize data, but storytelling to hopefully make you guys think why rotating so sharp is such an important aspect of patient safety. Can you turn up the mic a little bit? Is it? I want to make sure that I can hear. Okay. All right. Is this better? Okay. All right. I can't hear the feedback. So I hope I'm not yelling at you guys. All right. So despite the fact that I'll use storytelling, there's still some level of objectives for you to do. And do not worry about taking notes because on the link that you got earlier, it has the study guide and it has all the answers to questions you need to take. And I was forward to the questions. So be super easy. We'll go through the definition of what routine surgical shocks and near misses are. Understand the importance of reporting, we'll describe the impact of routine surgical shocks on patients, on the hospital, and also the nursing staff, and identify what are the future changes and leadership initiatives that can be done to help. Okay, let's start off with definition. So I'm going to start from the right to the left. So a sharp is anything like a needle, a blade, a guy wire, instruments, fragments. When I mean more, it's the tip of the gynecological instruments that are falling off. And it's retained because the patient has been closed up and they didn't realize it's not the eye until maybe it goes up later, X-ray, and they find something inside. Or there's actually some sort of health impact later on, so it requires the operation or readmission. So like I said, I'm going to be doing storytelling today. So this is a little girl called Caitlin. She was born in July 2016 in Florida. She was born with a gap in her aorta, so the blood oxygenation wasn't going into her body. And so the Johns Hopkins Hospital, the cardiovascular team, they did a miraculous surgery on her. But at the end of the surgery, some of the OR staff was basically concerned because the count was really right. They seemed to have a missing needle.
And then the surgeon could say, no, there's not possible. I'm like the best surgeon ever. And the second thing is there was a post-op scan that when they told it in post, there is a needle-like foreign body, but we couldn't tell because it's so hard to tell from the X-ray. So it was reported on the medical record. Then 2 weeks later, over the course of the next 2 weeks, she started getting sick. Remember, this kid is 8 weeks old. And so it got to the point where she started to turn purple. So then the parents rushed her to other hospitals where the surgeon opened up her heart and realized that they are able to find a half-inch needle right next to her wallet-sized heart. The surgeon took it out. Of course, when this situation happened, Tampa Bay News took the whole story and made it completely public. The surgeon got laid off, leadership got investigated. They actually closed down the complex surgery center until 2019. So what you're seeing now is true implication where it's not just the patient safety, the patient's now 7 years and she's fine, but it's also the impact of the nurses, of the surgeons, leadership, and financial. Next, it's near misses. Near misses is basically when you're counting and it's missing something. Typically, it's fine before the patient is closed, and so there's nothing is to be reported. But there's a lot of situations where there's a miscount and you couldn't find it, and you have to document it. You bring in an X-ray, and even if that can't find it, you have to document it on the EMR system. So one of the things that nurses are doing and surgeons are doing to prevent near misses, one is they do a systematic room search to make sure something's happening fine. The second thing is also triple and double check on the counting. I know a lot of checks. I'm going to just give it a check here. Number one is what is the highest number of needles in every count? 200, I heard. How much? 240. Okay. How many? 560. You won. The last I heard was 500, but you thought 560. What kind of surgery was that?
They said
It's a heart surgery.
they said New York.
Okay. So that you won. Okay. Second thing is how many of you guys have been on the knee on the floor trying to find needles? Oh, all right. You got to close. Okay. So I'm going to raise up a little bit and go from retained surgical sharks to retained surgical items. So if you look at retained surgical items, there's actually two components. There's the sponges and what we call the soft goods, and then there's the hard goods that are the needle, the instrument, etc. So what the data is saying here is, and when you're looking at the joint condition reporting, they basically put together as one as retained surgical item. In 2008, the retained surgical item count that's actually reported in the CMS system was 1 in every 5,000 population. Now, in 2021, it actually has gone up. Okay. Your numerator, it stays the same, and your denominator goes down. That means the frequency has gone up, right? So in 2021, it's actually gone higher. Now, how many of you use a smudge detection wand to detect service? Okay, many of you. So that means the technology to less reported cases, what's going on? So there's another report that's actually now showing the shift is actually moving from the sponges into more of the needle sharks. For a couple reasons. One is there are increased minimally invasive surgeries, which means their needles are smaller, the patient needle is also smaller, and also they're letting the dexterity that you normally would get with a free hand, you can do the same thing with the metal. And so that's contributing factors to why it is actually seeing more. So how many of you guys can name all 10 joint commission memory events? Wrong site surgery, area, falling. But retained surgical items has actually always been one of the top lists. Now, here are the reported cases. 132, 124, 106 coverage included. The numbers don't seem that big, but there's another report that shows the actual reported cases to CMS is actually representing only 3%. So you should take this number and multiply by 50. That's the reality of what we're seeing when we research data nationwide. So here I'm actually going to play a video of a survey that was done by a few surgeons. They were looking at what is the situation of retained exposed sharps and the impact on quarantine. And there's some interesting situation here. So I will let the surgeons talk about it. All right, so this is just some of the graphic again. Can you guys hear me? Okay, this is just some of the graphic. It's actually already on the guidelines. It will be usually fine. So we are almost done. Now I'm going to go through a few more slides about, now we know the data. What do we need to do? Then what are the contributing factors? So out of the studies, 75% of the contributing factors used by learners buckets. Number one is human factors. That could be distraction, that could be just fatigue, new team member. There's a lot of also traveling, new members. Okay, swapping in and out, insufficient staff orientation. So let me pause for a second from a distraction because we're sort of in the same room like an OR. There's a lot of noise, right? So what are some of the things you could do to minimize distraction while you're trying to count? What are some of the methods you guys use that is very effective? There you go. Turn off the music, yes. So if you are able to tell the surgeons and the rest of the team are want to turn off the music and they get back here, or if it's a policy that's actually used, that would be great. The second thing that I recently learned, and there's a lot of studies now looking at it, it's called transition gap. Introducing a transition period. What that means is when you're moving from one cognitive heavy task to another one, you should enter actually what we consider a transition period so that you can change time frame from one to another and subsequently perform better. Let me give you an example. So let's just say your task one, you are actually supporting a surgeon on the surgery, and now it's time for you to do the counting. The context of which you're doing the surgery is different from the context of which you're doing the counting, right? So a transitional thing that you could do could be as simple as, like, let's try it together. Close your eyes for a second, take a deep breath, blow it out, and start opening your eyes, but starting only at the first foot. Take a few seconds, and then the next foot, and then the next foot. So what you're doing, it's basically changing the way you're counting time in your head. So by the time you land on your second task, you're no longer taking the same context last time. This is what in the research now study for people who have to context switch all the time. It's a way for them to maintain the quality as they switch from one task to another task. Okay, so that's human factors. The second thing is leadership. So obviously, when there's not a policy around counting, not a policy around X-ray, not a policy around reporting, that becomes very difficult. Compliance. The third but not least is communication. So obviously in the situation of Caitlin, there was a breakdown in communication. There was a hierarchy situation. Communication could also be language barrier. It could also be different styles of communicating, or just a lot of travel nurses going in and out and not understanding the style of each other. So what can we do? Two things. One is the easiest way, stick with the same team over and over again if you could, because you know that you know each other's style. Second is if you can't do that from a rotation standpoint, you're a leader, you're trying to juggle different things, try to have extra outside activities where they are doing team building exercises ahead of going into surgeries. So this one has a lot of tasks, so I'm not going to make you guys to go through this, and I think a lot of you know. It's basically looking at when you're doing, before you go into the surgery, during the surgery, after the surgery, you need to have 2 people to do the counting, okay? I think a lot of you guys already know. The third one is if there is a miscount, a portable X-ray should be used. Now, what are the impacts on the patients? So we talked about is just like the story of Caitlin, reoperation, readmission. There's also could be physical harm. Recently, I think it was 2019, when at the key hospital in Tennessee, actually a patient who's 61 came in and do a heart surgery, lost a needle inside and had to reoperate and actually die on the reoperation. So physical harm, emotional harm, and death in the situation of this individual. But what about the operation, the perioperative team? You guys came in to do this because you want to save lives, care for people. The second victim syndrome is real. And the guilt that nursing and surgeon staffing feel, it's pretty painful. There's obviously burnout, alcohol use. Some of them actually need confession. And there's also the legal ramification. I was teaching the North Carolina class last week, and I mentioned about a recent verdict of another hospital that was a medication error by the bedside nurse that happened a few years ago. Do you guys know that story? You do. Remember how in the past, nurses were not liable for errors. And in that one, that broke the rules. And so now it opens up a whole door that if you guys do something and you report it, that could also bring ramification. Do you have something to say? Okay. It was a very interesting case, yeah. Didn't step up to support her. Yes, the hospital did not support her. All right, so what happened potentially in the hospital? Obviously, the malpractice payment, if there's a huge mistake, and over again, the percentage of reimbursement from CMS can drop. In the situation of Caitlin story with John Hopkins, they have financial loss, and certainly reputation damage for the hospital, right? So what can we do? We have two more things to talk about, and we're done. Number one is to develop a culture of safety. Taking continuation classes like this will help you get updated data on what's going on and inherent risk. Second, it's mandatory and voluntary reporting on both the accrediting as well as near misses. So again, I'm going to tell you one more story. This is relating to actual medication error and not breaking surgical item. So a few years ago, a doctor called Dr. Amy Emerson from Harvard, she decided to think about the concept of, well, do better performing hospitals to have less medication error? You would think that's the case, right? And the result was actually opposite. The best performing hospital has actually the highest number of medication error. And so then she was like, okay, I look at all the CMS data, I need to now know why. So then she sent out some research assistants out to those hospitals to figure out why. So it turns out the reason why the better performing hospitals have higher number, it's not because they're making mistakes, it's because they're reporting mistakes. That's the huge distinction. And talking about culture, the nurses, the staff nurses feel very supportive. They feel like they can open and talk about, okay, I made a mistake. What should I do? What should I have done? They also feel like they can talk about, have form questions. They can ask questions. They can, they feel that level of psychological safety. They know that their leadership is helping them to learn over time. So then, on the other hand, the two worst performing hospitals, what they found out when they were interviewing the staff nurses, they said that when they make a mistake, it feels like you get sent to the principal's office. You're humiliated, and one of them actually got she made a mistake on one blood, and she was put on probation. And so it's that kind of environment why I bring up stories like this to mention why mandatory and voluntary reporting of important both will be surgical and near misses. It's because how are you going to teach and train the nurses in the future? Last but not least, effective communication. I think we talked about that already. Next is, okay, leaders, what do we do when we go home? These are the steps. You start with an audit assessment. The second thing is when you're doing assessment, it's much better to actually include different groups, right? So what are the groups? The nurses for sure, the surgeons, the anesthesiologists. That survey that you saw, it started off with just surgeon and nurses. And what happened was doing one of the interview, the nurse does something, and the anesthesiologist was always the IC standard when it comes to cafe step motion. That's not the reality. And so you always want to have the third party to give you a different perspective. The other people that might be helpful is the people who are doing billing, the people who are X-ray technicians. So gather the group of people who have some touch in your OR room to do the assessments. Obviously, you need to, once you develop the solution, you have to audit your process. And also you need to celebrate success and encourage reporting. Last but not least, but if there's any type of malfunction with the product, especially overtime at the end, you need to report it to the manufacturer. AR also recommend using agile technology, just like the sponge technology that you use. There's one right here. Donnie over there, it's part of the Southeast Surgical. He has the product demonstration at one of the desks. And this is it. This is pretty much the summary of my class.